Okay, good morning, good afternoon, good evening. This is Dr. Kaz with the second part to our chat session on chapter 19, heart. Struggle continues. I apologize if in the background you hear my neighbor's dogs barking. Unfortunately, there's nothing I can do about that. So I'm hoping that they're going to be quiet for the next little bit while I do this video for you folks. Okay, let's jump right in and talk about an amazing event, and that is the cardiac cycle. The cardiac cycle is a very impressive physiological event. So let's highlight some of the important parts. First of all, when we're talking about the cardiac cycle, it is basically everything that occurs, all right, when you have a heartbeat. Okay, the famous lub-dub that you've heard about. We are now going to talk about when the doctor is listening to your heart with their stethoscope and they're listening to that lub-dub, amongst many other things they're listening for, right? But what's going on? So let's go over a few things. First of all, the heart is a pump, so it contracts and then it has to relax. So the term that we use when the heart is contracting is systole, and then when it relaxes, we call that diastole. Commonly used when listening to blood pressure, we have the systolic pressure and the diastolic pressure. So basically, we're measuring how much pressure are on the arterial walls during the contraction of the heart and also during the relaxation of the heart. So when we have a contraction, when the muscles are contracting, the actin myosin filaments are sliding past each other, forming cross bridges, and we are getting the sarcomere shortening, we are going to get an increase. This is very, very important, an increase in pressure. Okay, that's why when you have your blood pressure taken, all right, the systolic number is higher than the diastolic number. So contraction, increase in pressure. Okay, when the heart relaxes, we see a decrease in pressure. So back in chapter 4, you learned about gradients. All right, specifically concentration gradients, and with the process of diffusion, solutes will move from an area of high concentration to low concentration. All right, so now we're going to deal with a different kind of gradient. We're going to deal with what we call the pressure gradient. Similar scenario when we're dealing with more of something in one area and less in another. Okay, blood is always going to move down its pressure gradient. So that means it goes from an area of high pressure to an area of low pressure. This should help in trying to understand the cardiac cycle. Okay, so we're going to move from an area of high pressure for blood to an area of low pressure. And we've already learned all the different valves that are in the heart. And so the wonderful thing about valves is that it prevents backflow. It makes sure that blood only moves in one direction, and that direction is going to be dictated by the pressure gradient. Always forward, always moving forward, never backwards. Okay, so next important point of the cardiac cycle are the ventricles, the lower chambers of the heart. Those are the heavy lifting chambers. They do a lot of work. And so ventricular activity is the most important driving force. Let me repeat that. Ventricular activity is the most important driving force in determining these events of the cardiac cycle. So that being said, right, we will focus a lot of our time on the ventricles. So when the ventricles contract, we get an increase in the ventricular pressure. And because of this, right, the valves in between the atria and the ventricles, the AV valves, are going to be closed. They will be pushed closed. You will see a higher amount of pressure on the ventricular side than the atrial side. And because of that, that pushes the valves closed. Valves can only open in one direction. And those valves between the atria and the ventricles only open into the ventricles. Can never go back. Well, they can, but that's a pathological situation, and we don't like that. Okay. So AV valves, when the ventricles are contracting, will close. That makes sure that blood doesn't go back into the atria. Great idea. Now, during this time, the semilunar valves, right, those are the valves that are going to separate the ventricles from the great vessels of your heart, right? They will be pushed open. And then blood will then be pushed out into those great vessels. Okay, so keep that in mind. One-way direction for blood flow. Valves help to ensure that. All right, so when the ventricles relax, obviously, that is going to lower the pressure inside the ventricles. And in doing so, the semilunar valves now close. All right, and that's because the pressure inside the ventricles is going to be less than the pressure in the great vessels outside of the heart. And so since the pressure is decreased, there's no pressure keeping them open, those valves close, which is a good thing because that makes sure that that blood that we just pumped out of the heart doesn't come back into the heart. And then our AV valves during ventricular relaxation will open. Because again, the pressure in the ventricles are going to be less than the pressure in the atria, so the valves open up, and that allows blood to start filling up the ventricles. Again, a good phenomenon. That's what we want, okay? So keep these phenomena in your mind when you're going through the cardiac cycle. Ventricular contraction, AV valves closed, semilunar valves pushed open, blood leaves the heart. Ventricular relaxation, okay, we lower the pressure inside the ventricles. The semilunar valves now are closed, okay? This allows the ventricles to start filling up again for the next heartbeat, for the next contraction, right? And then the AV valves open up so blood can move from the atria into the ventricles and we can start filling up those ventricles. All right, so let's look at the beginning of the cardiac cycle. So as our cycle begins, this is what's happening. This is what is already going on. All four chambers are at rest. That means there's no contraction going on. Okay, they're just chilling. All right, so blood is now coming into both the atria from systemic circulation and from the pulmonic circulation. So blood is coming into both the left and right atria. We will start to see, all right, the blood entering into those atria, right? Meanwhile, the AV valves are open during this time. So that means that any blood that comes into the atria is going to then move on into the ventricles, and we're going to start seeing the ventricles starting to fill. We call that passive filling of the ventricles. One of the things that you need to understand is the atria pressure or atrial pressure is going to be greater than the ventricular pressure. All right, and because of that, that forces the AV valve open. And because of that, that allows, come on now, passive filling of our ventricles. So the atrial pressure is greater than the ventricular pressure, forcing the AV valve open. That allows for the passive filling of the ventricles. Meanwhile, during this whole time, the semilunar valves are closed. And that's because the pressure across the valve will see less pressure inside of the ventricles. All right, the pressure in the greater vessels or the atrial trunk is going to be greater. And so that keeps the valve closed so we don't get backflow, we don't get blood coming in from both the AV valve and the semilunar valves. All right, so all this happens at the beginning. All right, so I need to go over a couple different terms and phenomena, then I'll go through some pictures and show you how this whole process kind of goes down. All right, so during our atrial contraction and the ventricular filling, all right, that's going to be our first process here. All right, we have everything at rest at the onset of the cardiac cycle. Then the atria will start to contract, and that's because your SA node is going to start to depolarize and send out action potentials all throughout the cardiac cells in the atria. So as a result, we start to get that atrial excitation there. And the atria are going to contract pretty much simultaneously, and they're going to push any blood that is left in the atria down into the ventricles. So we're going to get that last little bit, all right, of blood volume down into the ventricles. So at the end of the atrial contraction, the amount of blood that are in the ventricles, all right, we give that a term. We call that the end diastolic volume. You should know this, EDV, end diastolic volume. That is the amount of blood, all right, that is present in the ventricles, all right, from the atria contracting and pushing the remaining blood from the atria into the ventricles. And after that, the atria are done. They are relaxed for the rest of the cardiac cycle, okay? So that's it. They've done their job. They push that little bit of blood into the ventricles. Cool. All right, so before, all right, before blood exits out of the ventricles, we're going to see this phenomenon called isovolumetric contraction. If you look at the word, iso means the same, okay? And then we're talking about the volume. So what that term means is the volume in the ventricles of blood will not change. We put in all the blood that we possibly can, all right? So that is the isovolumetric contraction, what we're going to see. So how does this start? The Purkinje fibers, you remember the Purkinje fibers, those are the fibers, all right, that are going to be found down at the apex of the heart that go upwards through all the walls of the myocardium of the ventricles. So they will start to excite the cardiac cells down there, all right, and we'll start to get a contraction. Now, during this time, as the heart is starting to contract, as the pressure rises, all of, okay, the volume will not change during this period. So to ensure that, we have to close all the doors to this room. So that means we're going to close the AV valves because the semilunar valves are already closed. So the AV valves, as the pressure rises, get pushed closed. So no more blood can enter in and no blood is going to be leaving. All right. So as the pressure rises, we're still going to see that the ventricular pressure, the pressure inside the ventricles, is going to be less than, all right, the pressure in the greater vessels or the arterial trunk pressure. So that means that the semilunar valves will still remain closed. They will still remain closed. So all the doors into this chamber are closed. We cannot change the volume of the blood there. So that's why we call it the isovolumetric contraction. As the ventricles start to contract, they're going to increase the pressure, essentially closing the AV valves so no blood can escape. But at the same time, the pressure in the ventricles has not overcome the pressure in the arterial trunks. So we can't force the semilunar valves open yet. So the volume does not change. So now, as the ventricles continue to contract and build up that pressure, eventually we're going to raise the pressure above the arterial trunk pressure. When that happens, our semilunar valves open up. And then the blood, remember, it's going to go from an area of high pressure to low pressure because the pressure inside the ventricles now is greater than the pressure inside of the arterial trunks. And so blood can then exit and leave the ventricles and go into the arterial trunks. So, important term here, commit this to memory. The amount of blood that leaves during a ventricular contraction is referred to as stroke volume. Stroke volume. And then, unfortunately, not every single drop of blood gets pushed out of the ventricles during contraction. So there's going to be some left behind. So the amount that's left behind, we give that a name, and we call that the end systolic volume. So at the end of the contraction, the blood that's left behind is the end systolic volume. So of course, we come up with our equation here on how to calculate the end systolic volume. Now, there's a couple ways that you can mess around with this equation. I personally like this equation a little bit better. Okay, stroke volume is equal to end diastolic volume minus end systolic volume. All right, I prefer that. If you want to get a quick calculation of the stroke volume, all right, how much is going to be ejected, then you just punch in, all right, your end diastolic volume, which is always going to be a larger value than the end systolic volume. So you're just going to take the difference of those two volumes to get your stroke volume. All right, so end diastolic volume can be anywhere from 140 milliliters to 130. I'll use the example here. All right, so we're going to see, all right, in our equation, 7 milliliters is the stroke volume, okay? Our end diastolic volume will be 130 milliliters. Whoops. And then the difference of that is going to be the end systolic volume, which is about 60, all right, milliliters. So again, you can mess around with the equation if you want to try to figure out what the end diastolic volume is, what the end systolic volume or the stroke volume. You have to have 2 out of the 3 values though, normally, okay? But on average, in a normal functioning heart, our end systolic, or excuse me, our stroke volume is about 70 milliliters, which is pretty good. Pretty good. All right. Come on, computer, work with me. All right, so the next part is going to be, whoops, there we go. Isovolumetric contraction. So you know that the old saying, what goes up must come down. Well, when a heart or when a muscle contracts, it's got to relax eventually, okay? So now, all those cardiac muscle cells in the ventricles have to relax. All right, and so when they do so, they start to decrease the pressure. So during this phenomenon, the pressure outside of the ventricles in the arterial trunks then becomes greater once again than the pressure in the ventricles. And when that happens, the semilunar valves close. But also what assists the semilunar valves in closing is not only that pressure gradient that's going on, but because the way they're shaped, they look like these structures here, okay, these curved upward structures like that. So as the pressure starts to drop down, of course, blood is going to want to go down the pressure gradient, and it's going to want to start to backslide into the ventricles. But because of the shape of these cusps, as they slide, as blood starts to backslide, it catches into the leaflets there, and it helps to close the semilunar valves. Cool design, really cool design. So they close down, boom. So you have 2 things that can help in closing of the semilunar valves. One is the pressure gradient, and also as the blood backslides, because of the shape of the cusps, it catches the blood and helps to close those valves. So boom, the semilunar valves are closed. The AV valves are still closed. They've been closed this whole time. All right, so we've closed all the doors to the chamber. So the volume of blood in the chamber does not change, hence the term isovolumetric relaxation. All right, so we do not have any valves open. So therefore, blood cannot enter or exit. So again, isovolumetric. All right, after that, okay, we start the whole thing over again, all right? The ventricles have relaxed, the atria are still relaxed, so all of our heart chambers are relaxed now. And because of that, all right, the pressure in the atria as blood is flowing in there is increasing, and eventually it overcomes the pressure in the ventricles, and that causes the AV valves to open up. And then our blood can now flow into the ventricles. So we get that passive filling once again. But again, our semilunar valves stay closed because the pressure outside of the ventricles in the arterial trunk vessels is still greater than the ventricular pressure. So they stay closed. So let's take a peek and look at all this fun stuff, looking at pictures here. I'm going to start with this fella here, number 5. All right, this is when, all right, everything's at rest. So your semilunar valves are closed. Here is one on the pulmonary trunk, and you can barely see the one for the aorta. All right, those are closed. So blood cannot enter into the ventricles. The only way that blood can enter into the ventricles is through the atria right now, because the pressure of the blood here in the atria, right, has caused the atrial pressure to be higher than the ventricular pressure. So that causes the AV valves to open and blood starts to pour in. So when we're looking at the cardiac cycle, 3 things, and that's why I like these pictures here, 3 things that you want to take into consideration. One is what's going on in the chambers. Are they contracting or relaxing? 2 is what's the pressure of the ventricles? And 3 is what's going on with the valves. Okay, so those are the 3 things that you should be taking into consideration. So in this phase here, it's 5, but I like to start off with this. All right, we just finished a heartbeat and we're about to start another one. Right, so all of the chambers are relaxing. Right, the ventricular pressure is less than the atrial pressure. So that means the AV valves will be open because the pressure is greater on this side than it is on this side. So it pushes the AV valves open. So blood starts to passively fill in the ventricles. The pressure in the atrial trunk is greater than the pressure inside of the ventricles. All right, so that is going to keep the semilunar valves closed. Okay, so let's start off now. We're going to start to get a contraction here. I got to go back to this slide here, starting with number 1. All right, atrial contraction and ventricular filling. So here's what's going on. The atria start to contract. You can see them kind of quivering and contracting. That's going to force the remaining blood that's in the atria down into the ventricles here, right? So the pressure is still greater here in the atria, okay? Atrial pressure is still greater than the ventricular pressure. So that's going to keep the valve open as it's pushing the remaining amount of blood into the ventricles here. And the pressure is still greater in the atrial trunks here and here, so that keeps the semilunar valves closed. All right, so then the atria stop contracting and they relax. We're going to enter into the isovolumetric contraction period here. So the atria start to relax. So the pressure now in the atria becomes less than the pressure in the ventricle. So that causes the AV valves to close. All right, that is going to be the lub in the lub dub when you're listening to heart sounds. So when you're listening to the heartbeat, it goes lub dub, lub dub. So the lub is the closure of the AV valves. So bam, they close down. Semilunar valves are still closed, but now we're starting to get the ventricles to contract. The Purkinje fibers all along here, all right, are causing action potentials to start to stimulate those cardiac cells to contract, starting at the apex first and then working their way up the walls here. So the contraction starts from the bottom, works its way up, which makes sense because we're going to push the blood upwards. Cool phenomena. All right, so the atria are relaxed, our ventricles contract, the valves are all closed, no change in volume. That is why it's called the isovolumetric contraction. So the amount of blood that is in these chambers here, the ventricles, is our end diastolic volume, right? End diastolic volume, because that was the amount of blood that was in the heart chamber or the ventricle chamber, right, at the end of diastole. All right, so we swing over here to the next phase. This is our ventricular injection. This is when we're going to start emptying out the blood. So the ventricles continue to contract. Now, again, the atria are relaxed. The atria are going to be relaxed until the end of this whole thing. All right, so we don't have to worry about them so much anymore. So the ventricles continue to relax, eventually overcoming, all right, that pressure gradient here across the semilunar valves. And now the pressure inside the ventricles is greater than the pressure in the arterial trunks here and here. And so that forces the semilunar valves to open up and push the blood from the ventricles into the blood vessels there. The AV valves continue to stay closed, making sure we don't have any backflow of blood. All right, they will not open. They can't open up into the atria. All right, so we start to see now our volume changing, all right, as blood is leaving the ventricles here. So that is phase 3. Phase 4 is our isovolumetric relaxation. All right, so the ventricles have contracted, forcing the blood out, all right? And as the blood leaves, the pressure inside the ventricles starts to fall. Right? When it falls below the pressure inside the atrial trunks, the semilunar valves close. That is the dub sound. Lub, dub. Anytime you hear a heart sound, that is a closure of a valve. So now the semilunar valves have closed. All right, the pressure continues to fall in the ventricles here. The AV valves are still closed during this whole time because the pressure inside the ventricles is still greater than the pressure in here as it's relaxing, but it is falling. So both valves are closed. The volume of the blood that's remaining in these chambers does not change, hence isovolumetric relaxation. But the volume that's remaining in these chambers, that's what we call the end systolic volume. All right, that is the volume of blood in the ventricles at the end of systole. All right, it just finished contracting. All right, and then we just start the whole process over again. Once, all right, the pressure in the atria becomes greater than the pressure in the ventricles, that forces the AV valves open. Blood starts to enter into the ventricles and we get that passive filling, but our semilunar valves remain closed because the pressure on the outside in those great vessels, in those arterial trunks, still remains greater than the pressure inside the ventricles. So again, that prevents that backflow. We start the whole process over again. All right, that leads me to this very important concept called ventricular balance. And just to let you know, if you're still not sure, all right, of the cardiac cycle, rewind, listen to what I just talked about, all right, but go over those important points of understanding pressure gradients, when the valves are opened and closed, what causes the valves to open and close. What causes the valves to open and close is just going to be that difference in pressure from one side to the other, and they can only open in one direction. So that ensures the movement of blood in one direction, no backflow, ever forward, never going backwards. All right, so the concept of ventricular balance is both sides of your heart. Remember, your heart has two circulations. It's got the systemic circulation and pulmonary circulation. Those are the two circulatory systems that are involved with the heart, right? So obviously the right side is going to send blood to the lungs to get oxygenated, and the left side of the heart is going to send the oxygenated blood out to the tissues of the body. So always equal amounts of blood are going to be pumped out by both left and right sides of the heart. So the stroke volume for the left side of the heart is 70 milliliters. The stroke volume for the right side of the heart should be 70 milliliters. Now, unfortunately, the left side has the harder job. It's got to pump blood out to the whole body, right? Whereas the right side of the heart only has to pump blood to the lungs, not very far, right? So we're going to see that the heart wall, the myocardium, is going to be much thicker in the left ventricle, which makes sense, all right? Which makes sense. It's just like if you always used your right arm all the time, well, we'll stay with the same sides. If you always used the left arm all the time, the muscles in that arm would be bigger, all right, because it's always working out. You'd see more hypertrophy going on. And so that's what we see here. And only because, all right, the left side of the heart has to pump that blood further. All right, now, if we lose that ventricular balance, all right, if it falls off, this is where you can start to see swelling in areas or edema. All right, congestive heart failure is an example of that, right, in which you will see, all right, an increasing amount of fluid, right, because the heart becomes a less efficient pump, and we start to get a backflow, and you'll start to see an increasing amount of fluid in the lungs as a result of that ventricular imbalance that's going on. All right, so now that we kind of understand the cardiac cycle and what's going on, I want to introduce you to the concept of cardiac output. We need to measure how much blood is being pumped out of your heart, right? And normally we're going to measure it in how much blood gets pumped out of your heart per minute. So we're going to measure that with liters because, again, the stroke volume is 70 milliliters, right? But over a minute, we're going to pump much more than just 70 milliliters, right? So this cardiac output is a great way to measure how effective your cardiovascular system is going to be, right? And so we'll use it, right, to assign certain values, but to determine, all right, the heart health for individuals, and especially folks that exercise quite a bit, all right, we're going to see the value, the cardiac output increase, and I'll explain to you why. So how do we determine cardiac output? Simple. Cardiac output is going to be, here's the equation down here at the bottom. All right, cardiac output is equal to your heart rate, how many beats that occur in a minute, times the stroke volume. Because remember, stroke volume is the amount of blood that is pumped out, all right, by a single ventricle per heartbeat, all right, per heartbeat. But now what we're going to do is we're going to see how much blood is getting pumped out of the heart by a single ventricle in 1 minute. So what we have to do is find out what the heart rate is, because the heart rate is measured by how many beats occur per minute. All right, the average heart rate is about 80 beats per minute. The range is for individuals is 60 to 100 beats per minute. So that's all we're going to do. We're going to figure out what the heart rate is. All right, and so the example you can see here is 75 beats. All right, so you have 75 beats per minute. All right, and then you multiply that by the stroke volume, how much blood that is getting pumped out per beat. And you'll see after our awesome mathematical calculations that your heart is going to pump out roughly 5.25 liters per minute, which is pretty much close to the total volume of blood in your body. Pretty impressive, right? Pretty impressive. So first of all, make sure that you know what the equation is for cardiac output, okay, which is going to be stroke volume times the heart rate. Okay, so when we're looking at our cardiac output, if you think about it, the job of the heart is to circulate blood out to the tissues, all right, and also to oxygenate blood by sending it to, all right, the lungs. All right, so our tissues, all right, have a certain demand depending on what they're doing. If you're exercising, you're going to increase that demand for the nutrients, for oxygen and whatnot. All right, but when we are resting, like I am doing right now as I'm sitting here, okay, my heart has to meet the needs of those tissues depending upon how much blood it's going to be pumping. So that's the important thing. When we're trying to maintain our resting cardiac output, right, the heart needs to always meet the needs of the tissues for oxygen, all right, so it can undergo its normal metabolic processes for those tissues there. So what we're going to see is kids, people with smaller hearts are going to have a smaller stroke volume. So they might have 50 milliliters, all right, that are getting pumped out. So in order to meet the tissue needs, all right, for oxygen, their heart has to beat faster. And that's true. Right? Children have a faster heart rate, right, than adults do. Smaller, like birds, for example, have a stunningly fast heart rate compared to an elephant, right? Because the elephant is much bigger, has a larger heart, is able to pump more blood out of its heart, right? So individuals with larger hearts obviously will have a larger stroke volume. So they will have a much slower heart rate. Right, but you will see that phenomenon in athletes, tremendous amount. I believe last time on our last video, I mentioned that cyclist Miguel Indurain, but it doesn't have to be just a cyclist, but anybody that's really going to be an endurance athlete. So cyclists, marathon runners, right? Those folks, all right, what will happen is your heart is a muscle, and like any muscle, right, the more that you use it, it's going to undergo hyperplasia. And so those muscle cells are going to grow in size. And so they'll be much more effective in contractility and forcing blood out of the heart, right? So they'll have a larger stroke volume. So therefore, the heart does not need to beat as fast as it would with somebody that's not an endurance athlete or somebody that has a smaller stroke volume. All right, the next term here is cardiac reserve, right? And this is basically a way that we are able to quantify, right, the heart when you're starting to engage in activities above that resting level. Like if I were to get up from this couch and start to go for a walk or start running, all right, we have to increase our cardiac output to compensate, all right, for those tissues needs here. So all we have to do, all right, is determine what your cardiac output is at rest, and then find out what your cardiac output is during exercise. And then all we have to do is take the difference from that. And that difference, all right, is going to be the cardiac reserve. All right, so again, this is a way that we're able to determine, all right, heart health, but we'll see in somebody, all right, that is healthy, and I would consider myself to be relatively healthy, but maybe somewhat of a non-athlete, my cardiac output is going to increase by fourfold compared to somebody that works out every day, runs all the time, maybe cycles and hikes every single day of the week, all right, theirs can increase up to 7 times. All right, compared to their resting cardiac output. All right, so now, in case you were wondering, how do we influence our heart rate? How can we change, all right, how fast or how slow our heart rate is going to occur? So we have a couple variables that we're going to go through, different things that are going to affect our heart rate. So we have a term, all right, for what can cause a change in heart rate, and we call those chronotropic agents. And so these chronotropic agents are going to influence our nodal cells. You remember the nodal cells? Those cells that spontaneously discharge, that have that autorhythmicity, right? And they're located at our SA and AV node, okay? So we're going to talk about how these chronotropic agents are going to affect the nodal cells in those locations. All right, so 2 things that we're going to talk about, all right, have to do with our control center. Remember the homeostatic model, all right, receptor control center effector, all right, we have 2 control centers. That's going to be our nervous system and our endocrine system. So what will often affect, all right, the nodal cells are either going to be, all right, parts of our autonomic nervous system or some of the hormones that we are producing. So chronotropic agents that increase the heart rate are called positive chronotropic agents. So if we're going to increase the heart rate, well, we know the part of the nervous system that increases the heart rate, that's the sympathetic nervous system. So therefore, positive chronotropic agents are going to undergo sympathetic nerve stimulation there. So what happens? Well, here's what happens, right? Because of that sympathetic stimulation, we're going to get an increase in norepinephrine, which is a neurotransmitter, right? We're going to get an increase in norepinephrine on the heart. Where does that come from? The adrenal glands, where we have epinephrine and norepinephrine, right? So our sympathetic nervous system is going to stimulate the adrenal glands to release epinephrine and norepinephrine from the neurosecretory cells, right, deep inside of the adrenal gland and the adrenal medulla. Okay, so boom, that gets pumped out into your blood supply. Norepinephrine and epinephrine are going to bind onto the nodal cells and increase the amount that they are firing off. All right, how do they do that? All right, we will see they will bind on to our beta-1 adrenergic receptors, and this is going to then stimulate that secondary messenger system. All right, so we have a G protein that sits in the plasma membrane. All right, excuse me. All right, we have a G protein that sits inside the cell. All right, and we have our adenylate cyclase there, okay, which is going to activate the G protein. That G protein is then going to create cyclic AMP, and then cyclic AMP is going to then cause what we call a protein kinase cascade. And basically, protein kinase is going to involve phosphorylation of something. And in this case, we are going to phosphorylate our calcium ion channels. Why? Because that is going to cause those channels to open and allows calcium to flood into the cells, which is great because we need calcium to flood into the cells so we can remove the troponin tropomyosin complex off of our myofilaments there, the actin, so we can get our cross bridge formation going. And that's what we see. So this is kind of what I was just saying on a larger scale. All right. So of course, here we are, adrenal medulla. All right, so it's stimulated by the sympathetic nervous system, releases epinephrine and norepinephrine into the bloodstream. That norepinephrine comes in, will stimulate these cells here, not cells, these transport proteins here, all right, our beta-1 adrenergic receptor, all right, that's going to activate our G protein or stimulate the G protein here, right, to be activated by the adenylate cyclase, which is going to create cyclic AMP, which is going to then activate our protein kinase enzyme, which is going to come over and slap, all right, phosphate onto these calcium ion channels, causing them to open up, causing calcium to flood into the cell so we can get more depolarization. Now, this picture here shows you several other chronotropic agents here. Okay, for example, cocaine. All right, cocaine inhibits norepinephrine reuptake, which means that norepinephrine will just be stuck here in the synaptic cleft. And what's it going to do? It's going to keep activating, all right, our beta adrenergic receptors here. All right, you can see here with thyroid hormone, it's going to then just add more beta adrenergic receptors into the plasma membrane of the nodal cells. So we can activate more G protein, so we can activate more of our protein kinase enzymes to phosphorylate more of our calcium channels. All right, caffeine, wonderful product, right, helps to inhibit the breakdown of cyclic AMP. So now we have a bunch of cyclic AMP floating around cytosol. What's it going to do? It's going to go over here and activate these enzymes. So you can see there's several, all right, positive chronotropic agents here that are going to help, all right, with increasing the heart rate. All right, so now you can see the value of thyroid hormone, amongst other things like having to deal with certain metabolic functions for our tissues. All right, so those are the positive chronotropic agents. What about our negative? All right, well, our negative are going to decrease our heart rate, and we know which of the nervous system is going to decrease the heart rate. That's going to be the parasympathetic nervous system. All right, so what we'll see here now is with our parasympathetic nervous system, we are going to be releasing that all famous neurotransmitter, acetylcholine. Acetylcholine is going to activate a different type of receptor. Those are called muscarinic receptors, right? So those muscarinic receptors, which are actually another name that we give to our potassium channels, right? That's going to then stimulate those channels to open up, making, all right, the cell lose potassium ions, making the cell more negative. So we're going to hyperpolarize, all right, the nodal cells. So therefore, of course, if we're moving away from our threshold value, it's going to take longer to get to that threshold value, hence slowing down the heart rate. So that is the negative chronotropic agents. So perfect example here, right? You can see of a negative chronotropic agent is our beta blocker drugs, right? Beta blocker drugs are designed to decrease the heart rate. And they do, and then overall, all right, if you're decreasing the heart rate, you can also decrease blood pressure. All right, how does it do that? It messes around with those beta 1 adrenergic receptors there. And so if it interferes with epinephrine and norepinephrine binding on to the beta 1 adrenergic receptors, then that is going to slow down that whole process that I just drew over here. All this fun stuff that you see, okay, all of this here will not happen. Well, I shouldn't say it will not happen. It just takes longer for it to happen. And so, yes, we use it for treating blood pressure. And one of the best ways that I can actually explain why is one of the ways that we calculate out blood pressure is heart rate times what we call TPR, total peripheral resistance. So if you look at that equation, okay, blood pressure is equal to heart rate times total peripheral resistance. Total peripheral resistance is basically, all right, how much resistance that your systemic circulatory system, all right, is placing, all right, onto the overall flow, blood flow. So for example, we know that if blood can flow through a large diameter much easier, it's going to encounter much less resistance. So if your blood vessels are vasodilated, it's going to decrease the resistance. Therefore, it's going to increase, all right, excuse me, not increase, it's going to decrease your blood pressure. But if all those blood vessels were constricted and your heart's trying to push that blood through those blood vessels, it's going to encounter resistance. And so that resistance will increase your blood pressure. Another way to increase the blood pressure is to increase the heart rate. But if we want to decrease the blood pressure, if we decrease your heart rate, we'll decrease the blood pressure. And that's what beta blocker drugs do. All right. Let me just get rid of that. All right, so let's talk about some of the reflexes, all right, that are involved with influencing our heart rate. Okay, so remember what a reflex is, and this is what I love about this chapter, is that we get to pull back some stuff that we learned in Bio 210. A reflex starts off with a stimulus that has to be monitored by a receptor, which will then transfer any sensory information to the control center to be integrated, processed, and then that control center is going to determine what the response to that stimulus is going to be. And when it does, it'll send out through motor control nerve signals to the effector what the response is going to be. So we have to start off with receptors. And we have two: baroreceptors, chemoreceptors. One senses the pressure, all right, on the heart walls and also on blood vessel walls. The chemoreceptors are going to sense what kind of chemicals are dissolved in our solution. And so in this situation, it's basically going to determine what the levels of carbon dioxide and oxygen are in your blood. So these receptors are going to relay that information to our cardiac center in the medulla oblongata. And then, depending on what the stimulus is and then what our reaction to that stimulus is going to be, it will influence either the sympathetic or the parasympathetic nervous system to change the cardiac output as needed, depending on, do we need more blood or less blood flow? Okay, so we have the atrial reflex, which is the Bainbridge reflex. This keeps, all right, the heart from overfilling like a water balloon and popping. All right, so we have these baroreceptors that are located in the atrial walls there. All right, and so they're going to be able to sense, all right, how much blood is starting to return back to the heart depending on the amount of stretch that's going on at the wall there. All right, so as you start to get more blood returning, all right, the stretch on the atrial walls will increase. So we'll get an increase in nerve signals, all right, arriving to the cardioacceleratory center in the medulla oblongata. All right, and then this will then stimulate, all right, the sympathetic neurons, all right, that go to the heart, and it is going to then cause the heart, all right, to increase its heart rate to move that blood through faster, because it's able to get it out of there. And if it's able to get it out of there, it will then cause less stretch on the atrial walls. So if we start to notice an increase in our venous return, that's the amount of blood that the veins, all right, that are bringing the blood to the heart, if they're starting to get more pressure because there's a larger volume of blood filling the atria, then the heart's like, oh, I got to get this stuff out of here. You know, I'm not even going to wait for the ventricles to be completely full. All right, we're just going to increase the heart rate and we're just going to start to move it out. All right, and that's because we've activated the cardioacceleratory center, right, which is the sympathetic nervous system governs that, and it will then pump that blood through faster. All right, so we know that stroke volume, all right, is going to be how much blood is leaving the ventricles per heartbeat. All right, and so a couple things, and we're going to learn about this now. All right, what influences our stroke volume? And there's three things that influence our stroke volume. This is important, so you make sure that you pay close attention to this. The three things are venous return, how much blood is coming back to the heart. All right, our ionotropic agents, we just talked about. All right, the chronotropic agents, we're going to talk about ionotropic agents, and then a new term called afterload. Okay, so I'm going to walk you through all of these. So let's start off with venous return. And if you look at the name, it's pretty self-explanatory. This is the amount of blood, all right, that comes back to the heart. It's returned to the heart. Now, normally, it is directly related to stroke volume. So if you have 70 milliliters leaving the heart, you should have 70 milliliters entering into the heart. All right, for example, that's what we're looking at. So venous return is going to help us to determine, all right, the amount of blood, all right, that is going to be in the ventricles prior to the contraction. And I'll explain all this to you here in a moment, all right? So our end diastolic volume is going to be influenced by our venous return. So another name that we give to venous return is preload. Now you notice we have a term up here called afterload, and I'll explain that to you here in a moment. All right, but the venous return, when we're talking about the volume of the blood returning to the heart, we refer to that as the preload. Right? And again, our preload is going to be partly what is going to be seen when we have some of that pressure of that blood stretching the heart wall. So if we increase our venous return, we're going to increase our preload, and we're going to increase the pressure, all right, on the heart wall as those atria are filling up with blood that is being returned to the heart. So that leads us to the Frank Starling Law. Awesome law. Very important that you get this concept down. All right. So when we're talking about the Frank Starling Law, all right, as our end diastolic volume increases, we're going to see, makes sense, all right, just like if you're trying to fill up a water balloon, as you fill it up with more water, there's going to be a greater amount of stretch on the wall of that water balloon. We're going to see a greater stretch on the heart wall. And as a result of this, we are going to achieve a better or more optimal overlap of our myofilaments, of the thick and thin filaments. So as that occurs, all right, we get that optimal overlap, more cross-bridge formations can occur, meaning we can get a much more forceful contraction when the heart contracts. So the more blood that enters into the ventricles, it will increase our end diastolic volume. And as a result, that's going to cause a greater stretch on the heart wall. And as a result of that greater stretch, we get more of an optimal overlap between the myofilaments, between actin and myosin. And so when it comes to time for the contraction to occur, when the heart contracts, it's much more forceful. So that means we can eject more blood out of that ventricle. And more blood means our stroke volume increases. Okay, that is the Frank Starling Law. All right, read through that a couple times just to make sure that you understand. Real simple. The greater the stretch on the heart wall, we get greater overlap between the thick and thin filaments, which means the heart can contract more powerfully. And so when it contracts more powerfully, it can eject more blood, and that increases our stroke volume. All right, so if we increase our venous return, all right, then that means that our venous return is going to increase the pressure on the heart walls, all right, and therefore we can increase the amount of time that it takes to fill those chambers. All right, so let me repeat that. Venous return may be increased if we increase the venous pressure, all right, or increase time to fill. All of that, all right, is going to help increase pressure or increase volume, all right, which will then still translate to increased pressure, right? We'll see this, all right, during times of exercise. If you exercise enough, your heart becomes more efficient in its contraction process of the heart cycle. You'll see that those people have an increased stroke volume because they're getting an increased amount of blood returning to the heart as they're exercising. So with our slower heart rates, we're giving our heart more time to fill. And you'll be able to measure that in athletes. Some athletes have a really low resting heart rate. Okay, they can have it in the 40s and 30s. All right, so with venous return, all right, what we'll see is, all right, if our blood pressure decreases, like if you're bleeding out, this is a problem, all right, and you start to lose a significant amount of your blood through blood loss, all right, your blood volume will decrease, which will also decrease your blood pressure, right? So what we'll see is a decrease in the amount of blood returning to the heart. But as a result of blood loss, your heart starts to beat faster. Right? But that's going to cause, all right, a faster heart rate doesn't give you enough time to fill. I shouldn't say not enough time, but you won't have as much time to fill. All right, so you'll have a decrease in your venous return. So two things can cause a decrease in venous return. Low blood volume, all right, where you're just losing blood, or a higher heart rate, okay? All right, so when we have, all right, our venous return and we're looking at it, all right, remember venous return, that's our preload. We will see, all right, with a smaller stroke volume, we will also recognize that our end diastolic volume has decreased. Right? If you remember, if you see a smaller stroke volume, right, then our value, remember the equation, stroke volume equals end diastolic volume minus end systolic volume. So if the end systolic volume remains the same, right, how much is left at the end of the contraction, and you have a smaller stroke volume, then conversely, all right, you will see a decrease in the end diastolic volume. All right, so basically what really keeps, all right, the amount of blood being pumped out by each ventricle, all right, equal is due to that Frank Starling Law that I just talked to you about, depending on how much filling that occurs. All right, keep in mind, all right, that the heart, all right, is going to react to the volume of blood I shouldn't say the heart. The ventricle is going to react, all right, to the volume of blood that's placed inside of it, all right, differently, all right, depending on what the volume is. Meaning, all right, if there's a larger volume of blood in the ventricle, all right, you're going to see more of a stretch. So the contraction will be more forceful. Whereas if there's less, all right, of blood, volume of blood in the ventricles, there'll be less stretch, all right, less optimal overlap between the thick and thin filaments. So you won't have as forceful of a contraction. So what we'll see, all right, if one side of your ventricles, right, is getting an increase in blood volume, all right, that one side will contract more forcefully. And eventually what you'll see is, all right, on the other side of the heart, more blood will start to return to that other side of the heart, all right? And eventually that other side of the heart, the ventricle, will get a greater fill. And it will also then contract more forcefully, because since one side of the heart is forcing out more blood, increasing its stroke volume, it will eventually catch up to the other side of the heart, because that will increase the venous return on that side, getting more blood then to the other ventricle, and then that too will then forcefully contract and then eject more blood. All right, so the second variable that can influence stroke volume is the ionotropic agents. All right, ionotropic, think of ions. These guys are going to alter contractility, which is how forceful can we contract. All right, and so this plays heavily on calcium. All right, remember, we have two places that we get calcium from. All right, one from the sarcoplasmic reticulum, and then two from the interstitial fluid outside of these cells. All right, but calcium has to go to one place. That's inside the cell, into the sarcoplasm. That's where the myofilaments are. All right, so when we're looking at the ionotropic agents, all right, we're going to see, all right, how the levels of calcium are going to affect the contractility of those cells. So there's a direct correlation, right? So we'll see that if we change the calcium levels, it's going to directly correlate to the number of cross bridges that are formed. Okay, so if there's more calcium, we'll see more cross bridges. If there's less calcium, we'll see less cross bridges. So our positive ionotropic agents are going to increase calcium. All right, how do we do that? Again, we're going to deal with epinephrine and norepinephrine, which is going, we saw it when we were talking about the chronotropic agents. It's going to stimulate the beta-1 adrenergic receptors, and that's going to allow more calcium to enter into the cell, all right, from outside of the cell. We're also going to release calcium from the sarcoplasmic reticulum, right? We saw how the thyroid hormone, our endocrine system, plays a role on that. It's going to up-regulate, meaning it'll put more beta-1 receptors into the plasma membrane, right? We'll see certain drugs, digitalis is one of the drugs that will also help with increasing calcium availability, all right, to the sarcoplasm, to our cross bridges there. All right, then we have our negative ionotropic agents. All right, our negative ionotropic agents are going to decrease how much calcium is going to be made available. And of course, if we decrease the calcium, then we'll have less cross bridging, then we'll lower our ability to contract, all right, or the force of contraction, right? So of course, we'll see with electrolyte imbalances, all right, potassium and hydrogen ions, all right? If you see hydrogen ions, that's going to affect, all right, the acidity. And of course, if there's an increase in acidity, or excuse me, I should say a decrease in acidity in your pH value, okay, you can cause damage, right, what we call denaturation to proteins. And if you have denaturation of proteins, all right, remember a lot of our transport proteins, i.e. channels, pumps, etc., okay, can become damaged with higher concentrations of hydrogen ions, which will make our pH value lower, making it more acidic. All right. And if we see increased levels of potassium, all right, increased levels of potassium can really mess up that membrane potential there. And that's why you will see when they do lethal injections, right? Potassium is one of the ingredients for the lethal injection. And actually potassium levels, if you ever have blood work done and it comes back and your potassium levels are higher, right? Doctors become concerned about that because it can affect the functioning of the heart there. All right, certain drugs, calcium channel blocking drugs are great because if we can block the calcium channels from letting calcium into the cell, then we can decrease the contractility of the heart, slowing the heart down, which is great for people that suffer from high blood pressure. If we can lower the heart rate, we can lower the blood pressure. All right, lastly, for the variables of stroke volume is afterload. And basically, afterload is a term that we get when we're talking about the resistance, all right, that we see in the arteries outside of the heart, okay, is the resistance in the arteries after we eject blood into the circulatory system. All right, remember, there's a certain amount of blood or pressure, we talked about this, all right, in the ventricle and in the what we call the atrial trunk. All right, and so the pressure in the atrial trunk is going to be our afterload. So when your heart is contracting, when the ventricles are contracting, we have to exceed the afterload. We have to have enough pressure to push the blood from the ventricles into the arteries outside of the heart. And so the afterload is that name that we give to the resistance in the arteries, all right, to the blood that's being ejected from the ventricles. All right, so one of the things that can increase the resistance or our afterload is plaquing of the blood vessel linings called atherosclerosis. That plaquing makes the diameter of those blood vessels smaller, therefore it increases the resistance. All right, yes, we see it in aging. We also see it in people with highly inflammatory diets. That includes eating garbage, a lot of fast food, processed foods, things of that nature. Okay, so we'll see, all right, smaller lumen to those arteries there, which will then cause greater resistance. And if we get a greater resistance, we're going to see a decrease in the stroke volume because we won't be able to push out as much blood, all right, each heartbeat, because the resistance is preventing us from doing so. Okay, it's like if I'm standing on one side of the door and 10 of you are standing on the other side of the door, and the door only opens up into where you're standing, I'm pushing as hard as I can. I might be able to open that door a little bit, all right? But if we removed, all right, everybody except for 2 people, it would be a little bit easier for me to open that door further, and then we can get more stuff out. All right, so you can see here, this picture is showing us, all right, how end diastolic volume, stroke volume, and systolic volume all play a role here, right, and how much blood we're going to eject. So first one is the venous return, okay? That is our preload, the volume of blood that is coming back to the heart, all right? Then we have our ionotropic agents, which are going to increase or decrease the contractility of the heart wall there, of the ventricles. And then we have our afterload, which is going to be the resistance that are going to be in the arteries outside of the heart. All right, keep in mind how we calculate the systolic volume, or excuse me, the stroke volume, and how we get the values for end diastolic volume and for end systolic volume. This is a great picture. Actually, which one? This picture, and I'll get to this. This is last. We'll come back to this. But this is a really good picture for you to really learn everything. But like really quick here, all right, when we're talking about venous return, this little flow chart should be helpful in regards to that. So we talk about venous return. That's how much blood is coming back to the heart, both atria. We're talking about the right and the left atria. All right. So if we see an increase in venous return, obviously, that means more blood volume will start to fill up, all right, these chambers, which will place an increased stretch on the wall of the heart. All right. So we've increased our preload. And as we increase the preload, all right, due to, all right, Frank Starling Law, all right, we get greater stretch, we get optimal overlap between the actin and myosin, which means we'll get a much more forceful contraction. And so we'll push that blood into the chambers, and the same thing will happen. If we get an increase in the volume there, all right, then we'll eventually get a much more forceful contraction seen in our ventricles, and we'll have an increase in stroke volume. All right, then obviously the same thing, all right, applies when we have a decrease in the volume of blood returning to the heart. Say you have a horrible car accident and you're hemorrhaging, you're bleeding out, your blood volume decreases, okay? And at the same time, your heart rate will increase. It's one of the first things that happens, all right, to try to compensate for that decrease in blood flow because of the blood loss, is that your heart rate increases to compensate for that. So a decrease in blood volume and an increase in heart rate will cause, all right, a decrease in venous return, or excuse me, a decrease in stroke volume. All right, our ionotropic agents, this is the second variable, just to kind of show you. Make that a little bit smaller there. Okay, so of course, you know, the positive ionotropic agents are going to increase the contractility of the heart. And in doing so, what they're going to do is increase the amount of calcium that enters into the sarcoplasmic reticulum. Okay, and if we're increasing the amount of calcium in the sarcoplasmic reticulum, right, that means that we're going to be able to increase our cross bridge formation, all right, by removing the troponin-tropomyosin complex off of our actin myofilament there. So we get more cross bridges. And then if we get more cross bridges, we get a larger contractile force. Harder contraction pushes out more blood from the ventricles that increases our stroke volume. And then vice versa, right? Same thing, right? If we get less calcium in the sarcoplasm, that means we can't get as many cross bridges occurring, right? We see that with our calcium channel blocking drugs, right? So we'll get a decrease in our stroke volume, right? Which will help to decrease our blood pressure. And then we've got our afterload, the pressure outside the heart, the resistance outside the heart, right? So we'll see a larger resistance outside the heart from plaquing, all right, or just say something that's causing vasoconstriction of these blood vessels, all right? And so we have a narrower lumen, right? Makes it more difficult for blood to flow through there, increases the resistance, and that causes a decrease in our stroke volume because it makes it harder for the blood to leave the ventricles, or as much of the blood as we would like to leave the ventricles. So we'll get a decrease in stroke volume. Okay, so keep in mind when we are talking about our cardiac output, all right, we are going to be taking into consideration heart rate and stroke volume. Cardiac output is equal to your heart rate times your stroke volume. So obviously, heart rate is going to be dependent on our chronotropic agents, our sympathetic nervous system, and our parasympathetic nervous system, right? So if we are going to stimulate the contractility, right, through the sympathetic nervous system, we are going to affect our SA node and increase its firing rate. All right, same thing with the AV node. All right, what we'll see is we'll see less of a delay. That again will increase our heart rate. And then vice versa with the parasympathetic nervous system, we're going to slow things down. We're going to slow down the firing heart rate of the SA node because we're affecting the nodal cells there, and therefore we're going to increase the delay, which will again decrease our heart rate. All right, stroke volume, think of what's going on with the heart wall. Right, if we are getting a larger blood volume coming into the heart, all right, that is going to alter the stretch on the heart wall. So that can increase our stroke volume. And the same thing, if we're getting less venous return, less of a stretch, less cross bridge formation, right, then we'll see a decrease in our stroke volume. Right, so those ionotropic agents, right, that's going to affect calcium entering in to the sarcoplasm, plays a big role on our cross bridge formation. More cross bridge formation occurring, more of a forceful contraction. Less calcium entering into the sarcoplasm, we'll see less cross bridges forming, and we'll have a less forceful contraction. And then of course our afterload, think of the resistance out in the arteries there. If we increase our afterload, we increase the resistance, that is going to cause a decrease in stroke volume. We'll see this in older individuals. So this is a great flow chart here that you should really pay attention to. All right, if you're still kind of confused, I would go with figure 1926 and see, all right, what effects are going to occur, all right, on your cardiac output and stroke volume or heart rate, because both heart rate and stroke volume are going to determine what your cardiac output is. So on the left side of our screen, right, the chronotropic agents are going to affect your heart rate. All right, just to repeat, positive agents increase the heart rate. Negative agents decrease the heart rate. Why? That's based on what is going on at the SA node and the AV node. All right, so that's going to be for the heart rate. Then we just got done talking about the 3 different variables that affect your stroke volume. Venous return, how much blood is returning to the heart, right? The ionotropic agents, which are the agents that are going to allow more or less calcium into the sarcoplasm, and then afterload, which is going to increase the resistance in the arteries outside of the heart. So if we increase, all right, our venous return, right, because our venous return directly correlates with stroke volume, which means if we increase venous return, we increase the stroke volume. If we decrease venous return, we decrease the stroke volume. That is different than afterload. Afterload is inversely related, which means if you increase one value, you have to decrease the other value. Meaning, if we increase the afterload, we decrease the stroke volume. Or if we decrease the afterload, that means we increase the stroke volume. And then you can see how both stroke volume and how our heart rate will then influence our cardiac output. All right, folks, I hope that helped you out. I know that was a lot to take in. There's a lot of concepts that are buried in with that material, so please really focus on trying to take your time with this material. I wish you the best of luck, all right, and have a wonderful, wonderful day.